Good afternoon. Welcome to the Ohio Chapter American Academy of Pediatrics Childhood-Led Poisoning Prevention Training. We are excited to have our first training of the fiscal year. We're so glad that you all are able to join us. My name is Alex Miller, and I'm the program manager for the Lead Free Ohio program with Ohio AAP, and I'm who has been sending you all the emails. Just a few housekeeping tips. Please make sure that your lines are muted and your cameras are off during the duration of the training. If you have any questions, please put them in the chat box. If you have trouble hearing or seeing, please also put those in the chat box and we will address them as we see them. Just a few other items. We have a website dedicated to all of our Lead Free Ohio resources. Please go to the website, and we have a RAT card, a toolkit, physician resource guide, tons of information around lead, and a bunch of resources that you can use with your families. Please register for our next training that is on January 28th. We will have Dr. Matthew Tien speaking from Metro Health, and he has a lot of great information to share with us. Some other trainings that the Ohio AAP has available, another lead training on how to introduction to lead and how it impacts environmental justice. This is not part of the Lead Free Ohio trainings, but it is a different training, and it is next Friday from 12 to 1. So if you're interested in that, Dr. Joel Davidson will be speaking from Akron Children's. And then we have other obesity related trainings that you can register for as well. If you would like to register for our toolkit, the link is there, and you can also get to the registration link from our website. This is an example of the resources that we have available: a family RAT card available in English and Spanish, a physician resource guide, and an interactive website where you can type in zip codes to see if they were high risk or not and need to be tested for lead poisoning. At this time, I will let our speakers introduce themselves and we will get started. Like I said before, please put any questions, comments in the chat box, keep your lines muted and your video off. After the training, slides will be available and a post-survey evaluation will be sent out. You must complete this post-survey evaluation to receive a certificate or your CME credit. Thank you, and I will go ahead and pass it over to Dr. Rupa Thakur.
Hello, everyone. My name is Rupa Thakur. I'm a primary care pediatrician at the Cleveland Clinic. I have an interest in population health and advocacy, so I serve as medical director for Cleveland Clinic's school-based health program, as well as youth strategies for our community health and partnerships team. And Dr.
Hello.
Newman, if you'd like.
Oh, yeah, hi. My name's Nick Newman. I'm a pediatrician and occupational medicine physician by training, and I'm based at Cincinnati Children's Hospital, where I'm the director of our Pediatric Environmental Health and Lead Clinic, as well as the Pediatric Environmental Health Specialty Unit here for Ohio. So thank you all for coming. I'm looking forward to this.
All right, so today we'll be reviewing the epidemiology of lead exposure in children, looking at the short and long-term implications of lead exposure, and finally reviewing anticipatory guidance and medical management of lead poisoning. Next slide, please. So we'll break this down into epidemiology, lead screening and testing, followed by a discussion of the management of elevated lead levels and prevention of lead exposure. Next slide, please. So the COVID-19 pandemic has created all kinds of complications to our lives. And specifically, we know that the percentage of people in the US who have deferred preventive care has increased significantly. This New York Times headline reflects a CDC report suggesting that 9,000 children with lead poisoning were missed in 2020. And locally, we saw a similar decrease in lead testing completion with a significant drop-off noted in 2020. Next slide, please. So let's look at the traditional epidemiologic triad as a framework to understand lead poisoning. Because we've all had firsthand pandemic experience with the pandemic, I'll use COVID-19 as a loose example to illustrate this framework. But the idea here is that the agent must be present. So for example, the presence of the virus. At the same time, certain host factors make a person susceptible to that disease. So maybe they're immunocompromised or have other risk factors. And then environmental factors can influence the development of disease, such as the presence or absence of masking, physical distancing, things like that. Next slide, please. Lead poisoning follows the same model. Host factors may include age, nutrition, and behaviors. Lead is present in paint and other sources. And the child's environment may specifically include deteriorating paint dust accumulation on the floors, things like that put them at higher risk for exposure. We'll move our way around this triad as we go through the coming slides. So we'll start with the agent, lead. Next slide, please. So what is lead? It is a malleable, corrosion-resistant metal that appears in multiple forms. Lead +2 is the type that our bodies can absorb. We've actually been using lead for various purposes for about the past 8,000 years. And as far as we know, the first report of lead toxicity came from the ancient Greeks, approximately 2,200 years ago. So the CDC actually refers to lead as the first known pollutant. Acute toxicity has been recognized throughout this time, but it was only recently that the risk of subacute exposure has been recognized. And it's clear that lead exposure has been increasing over time. Next slide, please. There was an enormous pickup in lead production in ancient Rome and Greece, initially found as a contaminant with silver mining. The contaminant was removed and used for plumbing and other purposes, and we now produce more lead than ever in human history. Next slide, please. So to put this into perspective, we'll look at the estimated lead burden of ancient people, a typical American, and in the case of overt lead poisoning. So these estimations are extrapolated from lead content found in bone samples. So for an ancient person about 10,000 years ago, the estimated lead burden in the body was equivalent to this one dot. I think if you hit next, we'll see our dot. There we go. A typical American in the late 20th century was exposed to 100 times more. I don't know, do we hit next again? Will that pop up? Oh no, they're already there. I'm sorry. My screen is too small. I can't see it. And overt lead poisoning is likely 10 or 20 times more than that. So this suggests that lead really wasn't in the environment until humans started digging it up and exposing it to the biosphere. Next slide, please. So next we'll look at environmental factors more closely. Next. So the most common source of lead, as we know, is lead-based paint. If you'll hit next, please, Alex. We know that 80% of Ohio's lead exposure comes from lead-based paint, but 20% comes from one or a combination of these other sources. Water contamination can reflect sporadic failures of corrosion control or low-level constant leaching of lead from pipes over time. And because we're drinking water all the time, you multiply the small amount of exposure by the large amount of water that we take in, and you can see that the total exposure can be quite large then. When thinking about water contamination, it's also important to remember that the municipal water lines or service lines are typically not made of lead. It's the lines from the service lines to the home that were historically made of lead. Lead pipes were banned nationally in 1986, although some cities or counties may have banned them earlier. And lead plumbing and fixtures were allowed until 2014. Lead contamination can also occur through occupational exposure. It can be present in our soil and our foods, herbs, and spices. Toys may be painted with lead paint. There are a number of traditional cosmetics, medicines, ceremonial powders that contain lead either as a main ingredient or a contaminant. So lots of potential exposures in a home. Next slide, please. The main way that lead levels become elevated was because of lead in gasoline, actually, which spread rampantly. The National Health Assessment Nutrition Examination Survey, which is conducted by the CDC on a continuous basis, has demonstrated this correlation pretty nicely. So the blue line here is lead in gasoline, and we see that as we reduced the use of leaded gasoline, we see a correlate drop in mean blood lead levels. Next slide, please. High-risk occupations include construction and renovation, those who work with lead batteries or lead recycling, welders, plumbers, firing ranges. There's occupational exposures throughout a lot of different careers, especially here in Ohio. Next slide, please. The AAP published this a few years ago, demonstrating that it all adds up. Lead exposure from a combination of sources can result in a child's elevated lead level. With, if you hit next, we'll see that water and paint dust are our top contributors. 80, yeah, next slide, please. There we go. So 80% of kids are exposed by lead in housing, as we mentioned before, and 2/3 of Ohio's housing was built during the lead paint era. This represents much of our inner city as well as rural housing stock in the state. Next slide. So how did we get into this situation where so many homes contain lead paint? Next slide, please. We discovered that lead paint was dangerous to children at the end of the 19th century, beginning of the 20th century, at which time it was banned in much of Europe and Australia. In 1921, the National Lead Company in the US admitted that lead is a poison, and in 1922, the League of Nations passed a treaty to ban lead paint, but the US at that time had declined to adopt the policy. Over the next 50 years, data was collected demonstrating the ill effects of poisoning, but it wasn't until 1978 that lead-based house paint was banned in the US. Next slide, please. As a point of interest, just after the League of Nations banned lead paint, the companies in the US became innovative in their marketing strategies and actually developed a campaign to market lead paint to children in the form of a paint book, inside of which was a booklet for their parents advertising lead-based paint. Next slide, please. So thinking about the historical context of lead exposure, we also need to think about the systems issues encoded in policy that have helped sustain inequities in populations at risk for lead exposure. When we look at lead-based paint in homes, it's of course not just the age of the house, but also the state of housing and neighborhood maintenance and other factors that play into this. Next slide, please. So lead poisoning is, because of this, a great example of an environmental justice issue. When we talk about environmental injustice, we're talking about the disproportionate burden of environmental health hazards in certain populations. We know that children are in themselves a vulnerable population, but also those politically or socioeconomically marginalized communities are at increased risk of lead exposure. The data shows that non-Hispanic Black children have almost 3 times greater risk of an elevated lead level compared to other populations. Next slide, please. So what makes children such a vulnerable population? Let's look at our host agent factor, or our host factors, to kind of understand what puts our little ones at risk. Next slide, please. There are a number of reasons that children are uniquely at higher risk from environmental hazards in general, including their physiology, developmentally, age-appropriate behaviors, their hand-to-mouth behaviors, their diet, especially infants and toddlers with limited diets, can lead to iron deficiency, which increases their risk of lead absorption. So we'll go to the next slide, please. Hand-to-mouth behavior is, as I mentioned, developmentally normal and appropriate in young kids, but it does represent a risk when kids are in that stage of oral exploration. It's important to remember too that older children who are a little bit more independent and may have less vigilant supervision, as well as those with developmental delays resulting in persistent hand-to-mouth behaviors, or those who have pica may be at increased risk for lead exposure as well. So especially for our children with behavior issues and developmental delays, definitely worth checking our lead levels. Next slide, please. Physiologically, younger children are also at increased risk of absorption of lead from the GI tract rather than older children or adults. We know that those with limited diets are more likely to be iron deficient, as I mentioned before, and that iron deficiency can increase lead absorption. We know that lead absorption is higher between meals. And if you could hit next, please, Alex. The combination of these factors result in infants and toddlers absorbing between 2 to 4 times the amount of lead compared to adults. Next slide. All right, so I'll turn the mic over to Dr. Newman for this part.
Hello. Yeah, thank you very much. So it's my job to talk a little bit about the implications of lead exposure in children. And as was just explained, I mean, I think probably physicians and other healthcare providers have been getting together for over 2,000 years talking about how bad lead is for all of us. So we're just continuing a very long tradition here. The next slide. So first of all, acute symptomatic lead poisoning in the U.S. is rare. I mean, I've seen this, obviously, a lot of us have seen this during our career. I certainly experienced a big uptick in like acute lead poisoning during the pandemic as children were stuck inside in lead contaminated housing. A few years ago, they had reduced the reference level, the CDC blood lead reference level, and that's recently been changed again down to 3.5. And this has created some problems of technical concerns because some of certain like lead testing devices may not be able to measure with that consistently with that amount of precision. And for the most part, when they changed the reference level, it was with the understanding that no amount of lead is okay, but that this really was a public health action and prevention level, not necessarily based on some clinical outcome. So, it isn't that below a certain amount, like it's okay and it's normal. And as you can see from the previous slides, what humans were exposed to, in the past was way lower than what we're getting exposed to now. Next slide, please. So once again, I mean, if you look in the textbook, the signs and symptoms of lead poisoning, behavior problems, irritability, abdominal pain, sleepiness, headaches, seizures, like these are all quite rare. Now, I could tell you, being in a center where kids get referred to for lead poisoning treatment, the thing that I see most commonly actually is abdominal symptoms, so like constipation. And unfortunately, we've had a number of kids with lead levels that were extremely high. So we have seen, changes in, headaches. We've seen changes in gait, et cetera. So, but these are actually very rare. Next slide, please. Yeah. So, although lead can affect just about any organ in the body, the primary organ that we're worried about in children is the brain. And part of that has to do with how the pathophysiology of lead and how it affects brain development, which we'll talk about briefly. But what the outcomes have been observed are decrease in IQ, increase risk for behavioral problems. And as this has been studied, as we look at lower and lower lead levels, we're not seeing a point where there isn't an effect. And just to put it into perspective, we published a study here from Cincinnati Children's last year, back in 2020, where we looked at lead in the air, and we could see effects on child development, neurodevelopment longitudinally over the first 12 years of life, depending on exposures to lead in the air that are a fraction of what the current EPA limits are. And so if it really, but our goal really should be primary prevention. We'll talk more about how we might be able to accomplish that. Next slide. And what's really interesting about this exposure outcome relationship with IQ and then also with like school performance is that it seems like there's more effect at the lowest level. And there's some really, we're not exactly sure what the pathophysiology behind that is specifically, because, once again, it's very hard, to study the human brain directly. People aren't, as a researcher, we don't go and say, well, hey, could we just have a little chunk of your brain? Most people are just like, no, you can't have a chunk of my brain. And I'll give you a piece of my mind, though. And so, I think a lot of this we have to measure somewhat indirectly, right? And the way we're able to do that epidemiologically is that we do similar experiments in similar populations in different parts of the world. And that's actually what this illustrates here, is that when you look at cohorts from all around the world, you see this consistent decrease in IQ at these low levels. And we do see this with other environmental toxicants, such as manganese, et cetera. And if you click the slide, I think it just, there's a little highlight that comes up. So the biggest apparent decrease is at the lowest low levels, which is what kind of drives the idea that no amount is good and we just need to keep going lower. Next slide, please. And then the same is true of school performance. So this is a study looking at about 30,000 children from the Detroit public schools. And they looked at like what was the child's highest lead level during the childhood, and then what was their probability of basically failing the standardized tests at different points in school. So third grade, my kids, we used to live in Michigan. No offense to any of the OSU people. My son goes to OSU now, so it's all good, right? Third grade, fifth grade, eighth grade. And what you can see, if you just click once, Alex, please, a little animation should come up, I hope. Yeah. So you can see, like, those of us who have been in practice for a while, 10 was kind of the magic number for lead. At that point, like, you're talking about a 45% risk of failing the standardized test as compared to a 15% risk for people who weren't exposed. And so that's actually pretty big, right? But what you can also see is that the curve starts out steeper and then levels off. So it isn't like you get to some magic lead level of 40 or whatever, and you fail everything. The probability never hits 100%. Next slide, please. And I would say, though, what parents notice, and I see this, because they come back to my clinic, years later, is the behavior problems. And lead it appears to affect, and I'll show you some of the proof of this in a minute, the prefrontal cortex. And this is where we think executive function is based, and ADHD is, of course, a problem with executive functioning. And when we looked at even very low lead levels, this was from a group here down in Cincinnati. They looked at a national study, and they found that about 25% of the risk of ADHD was attributed to just a very small amount of lead exposure. So like what we would, 1.3 micrograms per deciliter. So that's I think just something important to keep in the back of your head. The other thing that we see over time is this increased risk for antisocial behavior, problems with adult behavior. And the issue is that the impact is often delayed. So like you see kids who are a year old and their lead level is 20, and the parents are like, oh, well, the development's normal, everything's fine, blah, 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 blah. But then like they're 8 years old and they're like, hold it, like he's not acting right. And so I think it's like a lot of things where the inciting event is a distant from the actual observation of the outcome. And so it's hard sometimes for us to connect these things together. Next slide, please. And one of the things I think that's important to keep in mind is that if it affects school performance, that's also going to affect your ability to complete school. And so children whose lead levels are elevated, like early in childhood, are more likely to drop out of high school, and that their earnings are going to be about a third less than those who did not graduate from high school. All right, let me just reword that. That didn't come out right. So to say it another way, high school graduates make more money than those who did not graduate high school. So you're already like putting yourself like behind the 8 ball by doing that. And there's a study that was just recently done from a group down in New Zealand that was studying, it's been following the same group of people for about 45 years. And they looked at what the lead level was at around like age about 8. And they found that there was less social mobility in that group that had higher lead levels than the ones that had lower lead levels. And the interesting thing about looking at studies from like New Zealand, for instance, is that unlike the United States, there's no relationship between lead and socioeconomic status to start with. So lead exposure and socioeconomic status are not connected in New Zealand. So these were people that the lead was actually the main inciting event that reduced their social mobility. Next slide, please. So, a lot comes up about criminal disposition, and you see like in the popular press every once in a while there'll be a story about lead and crime, et cetera. And I guess the take-home point is that it's not like lead is the only thing causing this. There's obviously a whole bunch of things going on, but lead contributes about the same amount as some of these other factors. So, if you think about it, we'd like to try to deal with all of these things. And but lead may be one of the things that's most easy to define and also to actually do something about. Next slide, please. And because of the decreased earnings potential and as a result of behavior problems and decreased IQ, it's estimated that lead costs the US economy about $50 billion a year. And it's interesting that the return on investment on lead poisoning prevention, so that's like the kids don't get exposed in the first place. So for every dollar you spend on, let's say, maybe renovating housing, et cetera, it pays back at least $17 back to society. If you just click once, we'll talk about. So this is not like that far off from what like vaccines, $1 worth of vaccines pays back about, together in a similar range, right? So it's not inconceivable that we could actually do something about preventing lead poisoning. Next slide. So how do we think this works, right? So you're just like, okay, it's affecting the brain, it's doing all this stuff. So, as already discussed by Dr. Thakur, you have increased absorption, when you're low in iron. But the other thing is that lead mimics calcium, and your body has a hard time telling the difference between lead, iron, and calcium. And so lead gets transported around the body. It's not, in the past, people would say, oh, the blood-brain barrier isn't developed, and that's why it gets into children's brains. So that's not the case. I mean, the case is that lead is transported into the brain because the transporter thinks that it's something else. And the problem is that lead, in the form that we absorb is +2, which is the same as calcium, right? Calcium's +2, iron can be +2 or +3, right? But lead can be 0, +2, or +4. And when it changes, it releases these free radicals. And this is what we think is damaging the mitochondria in the brain. Because it's not acting like calcium and its valence state is changing while it's in a receptor, it may be interfering with the pruning of the dendritic connections. And so like that seems to be what's going on. But most of this has been done in animal models because, like I said, it's very hard to study like human brains, like actually like, in vivo, right? We could do it by imaging, and we're going to talk about that soon. And to try to explain away like why there's more effect at lower lead levels is very complicated. And there's just a little hint from some animal studies to suggest that extremely low levels of lead, so picomolar levels of lead, are equivalent to micromolar amounts of calcium in activating certain enzymes in the brain. And so there's some thought that perhaps what's happening is that lead is like accidentally knocking, turning on some enzyme that shouldn't be turned on. And that may be what's causing some of these downstream effects and why such low levels can be so dangerous. But like I said, this is more hypothesis based on animal studies. Next slide, please. So what I'm showing you here is a picture of kind of an aggregate brain. So some colleagues of mine here in Cincinnati have been following a group of people for the last 40 years with the primary goal of figuring out what does lead exposure do to you over time. And several years ago, they were able to do some imaging, and they found, so they created with the computer, they put all these brain images together, and they created kind of a normal brain. And I don't know, I put normal in quotes because normal is kind of a loaded term, right? So it was maybe like a typical brain. And so they then were able to look at the size of different structures in the brain, and then compare this kind of typical brain to it's kind of like that thing, here's your brain on drugs. So this is a case of here's your brain and here's your brain on lead. And what we found was that as the blood lead concentrations went up, there was a loss of gray matter volume in certain areas of the brain, most notably in that frontal and prefrontal cortex. So this gives just some inkling as to just a little view into the brain as to what maybe lead is doing to actually help to explain this symptoms and the other things that we're seeing. Next slide, please. So now we're going to we're taking out of gear, we're putting into a different gear. So we're going to talk a little bit about lead screening. And so in truth, from a public health perspective, this might be better named as surveillance or case finding. And that's because, in screening, one of the best screening tests is a colonoscopy, for people 50 and above, right, who are at average risk. So this is a test that's done universally. It's fairly easy to do, although not totally pleasant, but it's easy to do. And it also is able to identify people in a pre-disease state, because the whole point of doing colonoscopy is if they find a polyp, you can take it out and get rid of it, and that polyp is never going to become a cancer now. So you're trying to prevent colon cancer, and the way you do that is that you do surveillance, screening for polyps, and you take them out. And but the problem with lead is that once you find someone who's exposed to lead, we haven't found any effect that isn't, there's no threshold for effect, so any amount is bad, and we don't know how to actually reverse all these the effects of these exposures. So it starts to get complicated. And so, but then, well, hold it, the Preventive Services Task Force is not so keen on this, but the CDC and the AAP are. But they don't say to use it universally. They're saying, well, we probably should target who we test. And so really, we're trying to find cases. And why we're trying to find cases is that we're trying to find places where the primary prevention system has failed. Next slide, please. So, the whole point then is I guess I mean, it's an unfortunate example, but Flint, Michigan, where there was a failure in the corrosion control for the water system, which is primary prevention of lead exposure, right? That was detected that something was wrong by seeing that there was a little blip in what was going on with childhood lead levels. Now, most cases we're looking at are more localized. So, we might be looking for, the primary prevention in a house where there's deteriorating lead, where there's lead paint is that, well, it shouldn't be deteriorating, or that paint needs to be removed or covered over or replaced somehow. But so in keeping with that, most of the interventions that we do for a positive are public health interventions, although there are some medical management recommendations, which we'll talk about because that's relevant to all of you. But the goal is to reduce elevated blood lead levels as rapidly as possible. Because the same studies that have been looking at, lead levels over time, one of the lessons that we're starting to learn is that it isn't just like how high the lead level is, it's how long it stays high. And it may be that a lead level that's not like dramatically high over a longer period may be worse for you than one that's higher but then comes down rapidly. So the goal is to basically kind of reduce the whole area under the curve, like all the time and the amount. Next slide, please. So they have these lead screening questions, and I know a lot of people use them in their practices. And just click the button. We'll just go forward. Yeah. So this doesn't really explain much of the variability in the lead levels. All right, next slide, please. And they actually did a systematic review of these questionnaires, and they found that they've performed little better than chance at predicting lead poisoning risk among children. So in fact, like they actually performed less well than flipping a coin. So if you, because they were only good about 40% predictive value. So just click once. So even though we have another little animation, I hope. Yeah. So although the U.S. Preventive Services Task Force is not like really keen on lead testing for everyone, they basically are saying that the questionnaires are not useful and that you have to use other mechanisms to try to identify who would be at risk. Now, there may be situations where these questionnaires could be helpful, but overall, they fail in one gigantic account in terms of age of housing, because a lot of people who live in high-risk housing have no idea how old it is. I mean, I talked to a mom and I asked her, like, how old is your house? And she said, I don't know, like maybe it was built in 1960. I'm like, okay. So I looked it up on the auditor's website, Hamilton County Auditor's website. The house was built in 1820. So yes, it was old, but it was way older than she ever would have guessed. And I think that's where a lot of this falls short, because a lot of people really don't know like how old their house is. Next slide, please. So the take-home point is that just follow the local public health guidance on testing. If they say, do this, then do it. And for ODH, they've actually made it fairly simple for all of us. Next slide, please. So who needs to have their blood tested for lead in Ohio? Well, by zip code, because that's the state law, and high-risk zip codes, which will show you the map in a minute. Medicaid patients at 1 and 2 years of age, because that's also the state law. All high-risk children, so those are the people who are above, right? And so those are kids who live in pre-1950s housing or pre-1978 housing, or if you have some clinical suspicion that they're exposed to lead. So, if some, grandma comes in, this was like a real life story, like she was very concerned because her kid, her grandkid was at the house picking away at the banister and was playing with these and then touching their fingers in their mouth. So she was worried about lead. We don't know what the age of the house is. We don't know any of this other stuff, but like, gosh, well, if you're picking paint off and you're putting it by your mouth, there's a good chance there's lead in it, because 2/3 of the houses in Ohio were built during the lead paint era. So it's not inconceivable. Next slide, please. So, like, how do you test for lead? Well, you can either do capillary sample or venous sample, and it all depends, like, in your practice, which works best for you. Understand that if if you have a capillary sample that's abnormal, so like the health department would say 5 or above, then that needs to be confirmed with a venous draw. I would say that one of the good things about a capillary sample is that it could come back high, but then the venous sample comes back low. So that's actually an opportunity for primary prevention. Like you've identified that there's some kind of lead in the child's environment, and then you can actually give some advice as to like where that might be coming from, and actually maybe help them prevent the child from actually getting a dose of lead internally. The next slide, please. So just so you know, like by state law, all Ohio residents have to have their heavy metal levels reported to the Ohio Department of Health within 7 days of them being drawn. And this is all stored in the Healthy Housing and Lead Poisoning Prevention Surveillance System, HELPS. And which is way better than their old system. And actually ODH has one of the better systems across the country, because I've dealt with like health departments in other states. And then they update, the public information warehouse has this data available. And if you remember the slide that had the COVID testing, that's data that we pulled from the public health information warehouse. Next slide, please. So like, where are there high-risk zip codes? Well, if you look, all right, so the zip codes that are not high risk are the yellow ones. So those are mostly kind of the exurban areas around and between Ohio cities. And pretty much everywhere else is considered high risk. So, you know, you're in a rural area, gosh, a lot of rural Ohio is high risk. If you're in an urban area, well, yeah. And so there's a lot of places where children can be exposed to lead that maybe isn't on everyone's radar. Next slide. Yeah, most of Ohio is considered high risk. So we'll move on into primary, secondary, tertiary prevention. Next slide. So this is like an interface between clinical medicine and public health. And we each have roles that are complementary. And so clinicians do what? We do primary prevention. And so does public health, right? They're helping with, you know, testing and surveillance of the environment to try to prevent lead exposure. It's a job of clinicians, though, to test kids, depending on what and report the results. And then public health decides, oh, do we investigate this case or do we just track this? And then we do medical management, they do enforcement. So, but without each other, we can't actually get the whole problem solved. Next slide. So there's a lot of things on here, but one of the things, and we talked about this in our QI project we did with the Ohio AP last year, is that really, if you look at the studies, if children are growing up in an environment with lead hazards, their lead level will start increasing at 6 months of age. May not be super high, but that's where you start to see it start to come up. And so the time to think about doing, you know, primary prevention and anticipatory guidance is at least 6 months of age. Next slide. Yeah, just keep going. So primary prevention, I mean, if housing is like 80% of the problem, so avoid lead contaminated housing. And actually, one of the most cost-effective things to prevent lead exposure is to just simply follow the current EPA guidance on renovation, repair, and painting of pre-1978 housing. And I have brochures in my clinic. EPA has a nice website with YouTube videos and all kinds of stuff. And really, this is the biggest bang for your buck, like not getting exposed in the first place. A good diet is helpful, particularly a diet that's high in iron. Studies have been done mostly in outside the United States that show that children who are iron deficient, and they may not be anemic, but kids who are iron deficient will absorb way more iron, and if you correct that, they will absorb less. Calcium is also helpful because like that also competes with lead, and vitamin C enhances iron absorption. So like the whole system like works together. And yeah, I'm just reiterating the renovation, repair, and painting role. Next slide, please. And these slides had to be approved by ODH ahead of time, so we haven't put on the change in the CDC guidance. But yes, now the quote, acceptable lead level, if you want, we started at 60 back in 1960, and now we're down to 3.5 in 2021. Next slide. So I think what's important, and this is relevant to what just happened in terms of the CDC new guidance. It was back in 2012, instead of someone just picking a number out of a hat as to what the cutoff or level should be, they decided to tie it to population data that they had from the NHANES study. So as the average lead level in the United States has been dropping, and therefore, you have your bell curve, and so all the people out at the 97th, percentile, that number also is dropping. That's what tells the CDC what the number should be. And so now that number is 3.5. There was a question, and it flashed up and disappeared. So ODH is in the process of updating its programming right now. So there's more to come on this, and we can discuss this when we have some time at the end. Next slide, please. So yeah, we talked about acute lead toxicity. This is really super uncommon. Next slide. So if I would stress like one thing, the main treatment is to stop the exposure. I get calls because I do a lot of lead chelation here. I get calls like, oh, what's the dose of the chelating agent? I'm like, where's the source? I don't know. We don't know where the source is. We just need to get this kid on chelation. I'm like, it's not going to work unless you stop the exposure. And they're like, oh, okay, well, all right, well, maybe I'll call somebody else. But the point is that the main thing is to stop the exposure. Optimizing the diet is secondary, and chelation is like the last thing. Okay, next slide. So for lead levels under 3.5, so we have to like basically, because 3.5 is the new 5, right? So understand that the geometric lead level, it says less than 2. In fact, the geometric mean lead level for children in the United States is 0.82. So it's actually quite low. It's recommended that you just don't ignore this, but that there's some follow-up with these kids. And for kids who are tested below 12 months of age, they probably should be tested a little bit more frequent, because you imagine, like, let's say you do it at 9 months or something. That kid's not walking around, the lead level was, 1.5. You're just like, okay, well, what the heck? But just think about it. It's like, okay, well, if the conditions have changed, like if that host environment, agent triad has changed, like you need to think that maybe there's going to be more exposure. And we want to provide anticipatory guidance at this point. Next slide. And this is, we're not going to go over all this because this is taken verbatim from the ODH medical management guidelines on their website. It's just to kind of anchor this so people know visually when you look at the guidelines where we are. Next slide. So as the lead levels are going up, you want to follow up with the kids more frequently. The health department will be activated for lead levels of 5 and above. We talked about nutritional advice. We might want to consider looking for iron deficiency per the AAP guidelines. And then early intervention is now will now automatically get engaged for lead levels of 5 or above. There have been no decisions as to what to do with 3.5 as of yet. Next slide. And early intervention basically would like to try to address nutritional issues, as well as to identify any developmental or behavioral problems in the children. And to be honest, these services are still fairly ill-defined. They're still trying to figure out what the optimal set of services should be. And there's been a couple of pilot projects in Cuyahoga County to try to optimize what Help Me Grow can do. But often what I have found is that Help Me Grow is often calling the families before the health department's even calling, and the parents are just like, hold it, what the heck? So I think one thing that might be helpful is to kind of prime the parents with the idea that, oh, if the lead level comes back, 5 or above, you may get a call from early intervention, and don't freak out about that. Next slide. So as the lead level goes up, you want to confirm these levels more frequently. And then you can certainly reach out to someone like me or your friendly poison control center to help out. Now, the Ohio Department of Health will be contacting the family to do a home assessment at this point. Next slide. And skip over. And then these are the kids that you get more worried about, like that you may need chelation therapy. But the key is you want to not lose track of them. So you want, if this was a capillary sample, you want to verify this quickly, right? And then if we're not going to talk about chelation other than the cautions against, like when it shouldn't be used. But really, like this isn't done that often. There's been issues getting the drugs themselves because they were on shortage. It's best to work with someone who does this all the time. And I'm certainly happy to help people out, or in your local institutions, you may have other experts who can help you. Next slide, please. And you can, yeah, keep going. So the thing with these chelating agents is that they're designed to bind these metals and make them more soluble in water so that they can be excreted. The unfortunate thing is that it grabs a whole bunch of different metals sometimes. And yeah, we want to get rid of the arsenic and mercury, but not necessarily zinc, calcium, and iron, right? So also having said that, these can be toxic to the liver, bone marrow, and kidney, and the approved uses are extremely limited. So, a lot, and, we've heard a lot, the last year about FDA approval and stuff, and if we can talk offline about how these drugs were approved initially in children. And next slide. So the problem with chelation is that the benefit is fairly limited, right? So like chelation has been shown to prevent death from lead poisoning, but there's really no evidence to show that it's beneficial for lead levels under 45. And this was proven through a double-blinded, placebo-controlled, randomized controlled trial of Suxamer. And they saw no change in neurodevelopmental outcomes. And these are looking at kids whose lead levels were between 20 and 44. And the problem was that there was some hint in that study that that the kids who were treated with Suxamer actually had that Suxamer is also neurotoxic, is what part of what that came out, and that's also been confirmed with animal studies. So we want to be very judicious in the use of chelating agents, is really what I'm trying to get across. Next slide, please. And part of the issue is like you're trying to get just a click, because I think a couple of things come up. You've got like these two different, you have multiple different compartments, but like we can only measure the blood, right? And so the half-life in the blood is about a month, but the half-life in the bone is years. And so you can get the lead out of the blood through the kidney with chelation, but it's very hard to get it out of the bone. And so you end up like either having to treat multiple times, and there's more chance of toxicity, and et cetera. So next slide. I think a couple of little things will come up. Yeah. So public health responds to lead like three ways, like through education, investigation, and enforcement. Next slide. So lead levels 5 and above, public health will contact the family. Often this will be over the phone, and they'll administer a risk assessment questionnaire. Certain jurisdictions will have programs for nurse visits and things like that, but that's actually fairly uncommon. Next slide, please. And a lead risk assessment, entails someone walking through the house using this device, which is an XRF scanner, to look for sources of lead, collecting dust web samples, and then doing case management and education as to what they can do until the problem can be solved. Next slide. And just to keep in mind, lead abatement is the property owner's responsibility, not the renter's responsibility. And if there are lead hazards present, the health department will place orders that these need to be fixed. And they're supposed to be done within 90 days. And I can tell you, the way the system works, the enforcement of that is more spotty than you would like. But luckily, the state of Ohio and various health departments, including the Ohio Department of Health, has a lot of resources available, like $85 million worth of resources to abate housing, and take care of these problems for family, particularly low-income families, but also middle-income and even higher-income families can qualify for tax credits. Next slide. And then in our materials online, you'll see like a little flow chart of like potential workflows for an office setting to help like integrate this into your setting. Next slide. So basically, I mean, the things to take away is that lead testing is required for high-risk children in Ohio at 1 and 2 years of age. And high risk is defined by either living in the high-risk zip code, which you can look up on the Ohio AAP website, or the children on Medicaid, regardless of what zip code they live in. Primary prevention is preferred because we can't, this no amount seems to be okay. And then secondary, tertiary prevention, we're stopping the exposures and then addressing the risk factors, but try to stop the exposure. And it may be simpler than you think. I mean, sometimes a well-placed piece of tape over flaking paint ends the exposure. And once again, like chelation is really only meant like once you get like all these other things dealt with. Next slide, please. And that should be it. So thank you for attention. We have a few minutes left and I'm more than happy to stick around beyond the hour. So thanks a lot for tuning in.
Great. Thank you both, Dr. Tekler and Dr. Newman. We just have a few questions. One was, can adults be tested for lead by the local health departments?
Generally, my experience has been that adults just, those that already are being seen by a doctor, like any doctor can order a lead level. And particularly if there's a thought of exposure and you just put the right ICD-10 code with it and it should be okay. The health departments, for the most part, there were programs for this, and as far as I know, a lot of that money is dried up. Certain workers who may be enrolled, like let's say they work in a lead battery plant or something like that, they may already be enrolled in a workplace lead surveillance program, in which case the employer will be paying for it.
Great. The website for the zip code map, I will send that via email out, and then we also have the interactive map on our Ohio AAP, Lead Free Ohio website. And then another question, do you have any data on capillary versus venous draws in relation to adherence? An office gives patient lab order and needs to do a lab via having capillary draw available in-house.
Yeah, so I can try to address that. I mean, I just know from this, the projects we did down at Cincinnati Children's about 10 years ago, where we found basically, we were ordering the lead level almost 100% of the time. The parents were getting it tested maybe 60% of the time when they were going to the lab across the hall, because we weren't doing like in-office testing. When we started in-office testing, which we did venous testing because, well, anyway, this long, complicated story, that improved the adherence like to 90+%. So I think if anything that you can do while people are actually like, live in the room, or, not having them go somewhere, you're going to see a big improvement, whether you do it capillary or venous. So if you can only do capillary, it's better than not doing it. That would be my thing. Don't let the perfect be the enemy of the good.
Great. Let's see. And then there was a question about the CDC using 3.5 milligrams, and you kind of addressed that a little bit.
Yeah. So we, as part of the Pediatric Environmental Health Specialty Unit Network, we rewrote our medical management guidelines to adjust for the 3.5. And I believe the National AEP has a link to that. But we're in the process. There's a work group, I think, that's forming for the state of Ohio. And so there'll be some, it isn't just like what we do in the office, because like, honestly, at our primary care clinics down here, we just kind of assume that no amount of lead is okay. And so we kind of do the same thing for no matter what level. So going to 3.5 didn't change a lot for us. But on the other hand, public health has to really think like, okay, what resources do we have? How do we spend this money? The people we have, like, where do we put all that? And so I think that's the nut that they have to crack. And so, for our perspective as pediatricians, I think just reducing it to 3.5 just tells us that there's really no number that's really all that, when the level's below 45, like, all the numbers are bad, basically. I mean, there's badder and baddest, I guess, but like, if you already have a kid that's like 5 times what the national average is, I mean, if someone came in with a cholesterol of 500, you'd be like, oh, we need to do something about that. And somehow or another, we've thought that, well, lead, it's a different thing, but it's just another, like another risk factor, just like cholesterol would be.
Great. Are there any other questions that anyone would like addressed at this time? If any other questions come up, you can also send me an email and I can send them to Dr. Tekler and Dr. Newman to get those answered. The post-survey evaluation is up on the screen now. 1 CME credit is available, and you must fill this out to get a certificate. So please let us know your thoughts on this training and fill that out. I'll also send it via email as well. And I put it into the chat. And then if you have any questions, please feel free to email me. You can access our resources and our toolkit on the website. And please let us know. Oh, there's one more question. How long do you wait to retest after intervention?
You mean like if they do something at the house, or if you can unmute?
Yes.
Okay. So typically, if the lead level's, let's say, under 20, it's probably a good idea to recheck it in like 3 months or so. Sometimes though, like if they're going to do, let's say, a home intervention, the studies have shown that you'll see transient increases in the lead levels after like a lead abatement is done in a home. And so even if the family isn't there, because it stirs up some stuff. So sometimes I will like have the, time my follow-up based on what's like going on in the outside world, if you will, like. I don't know, Dr. Tucker, do you have any other thoughts?
No, I agree. And the medical management table put out by both ODH and AAP has some nice interval follow-up for based on just the degree of the lead elevation. But in terms of interventions to the home, I would say a few months is typically what I.
Because part of the problem is that the half-life in the bone and the blood is so different that I don't, basically the reason I'm rechecking is to make sure it's not going up significantly, because I know that it's going to take time for the lead level to come down. But I just want to make sure that we're not having a situation where something is getting dramatically worse without us knowing about it. And balancing that against, like, who wants to bring your kid in to get poked all the time. And so it's kind of just threading the needle there.
Well, thank you all so much for speaking, and thank you everyone for joining us today. Please let us know if there's any questions, and I will send out the survey online. Thank you, Dr. Newman, Dr. Thakur, and have a wonderful weekend. Thank you so much, everyone.
Yeah, thank you all for tuning in.
Thank you.
Bye.
Bye.